Thank you very much, everybody. I'm mindful of two things as I come to the stage. One is what a privilege it is to be with you and to be invited back to be with you again for the third or fourth time. This is a really wonderful audience. I'm mindful, number two, of the fact that we're the only thing standing between this audience and lunch, which is probably the second most dangerous place to be after standing between an audience and the cocktail hour. But at any rate, I'm delighted to be here. Why don't we begin by, I'll begin by asking each of you to give just sort of a quick thumbnail of what you do and what you like most about what you do. And I'll answer my own question first. What I do mostly is read a teleprompter, okay? It's an extraordinarily complex skill. It takes years to master. You go through internships, residencies, and finally maybe you get good enough to do it. But actually what I enjoy most about my job is that I learn something new every day. I get to interrogate, question intelligent people, and I get to learn something fresh every day. Ellen, so tell us a little about what you do and what you like about it.
So I'm Ellen Lukens. I'm the Deputy Director of the CMS Innovation Center. And as many of you I'm sure know, the CMS Innovation Center is tasked with implementing creative and innovative payment service delivery models. And I know some of our participants are here, but those models essentially have to meet two criteria. They either have to maintain or improve quality or maintain or improve cost, and hopefully both of those. So in terms of thinking about, and prior to that, I actually worked for Avalier Health, which is a consulting firm, and actually led the provider practice there. So in terms of what I love about my job, I think you actually just heard from the previous speaker that CMS really tries to balance how we can improve care for the beneficiary and also being stewards of the taxpayer dollars. And so every day I'm talking to people like you who have something that they're really excited about and think can improve care for beneficiaries, which is really exciting.
So my name is Mark Michalski. I'm the CEO of Ascertain. We work on automation solutions for healthcare systems. We work in places like transitions of care and case management, RCM, and the pharmacy. And my favorite thing about this job is we talk a lot about artificial intelligence in this room today and just generally, but when you actually start to apply it and you see how it starts to impact people's day-to-day workflow, their life, there's this, with this particular type of technology, there's this click that happens sometimes where it's like, oh, things are really gonna be different soon. That's my favorite. I like seeing that, and it happens frequently now.
There's a lot that's going to be different, and when you think about all of the new medicines that are in the pipeline, the new therapeutics, the new devices that are coming along, I guess the critical central question is, are today's payment structures up to the job of handling these new technologies? And if not, what is the central most important reform that needs to be brought to the party so that the payment structures and methodologies are up to the job of new medicines that in some cases are going to be highly individualized to you and you alone? Ellen?
Yeah, so at the Innovation Center, I'll just use one example. And again, we do model tests. So we essentially change payment for one group and then have a control group where we observe those differences. So we have one model that we're working on now that you may have heard of called the Cell and Gene Therapy Access Model. And the first therapy we're focused on is sickle cell disease. And this model essentially, on a voluntary basis, works with manufacturers and states to define an outcomes-based agreement that the states can essentially adopt into. They're not required to, but they can choose to participate in it. And I heard in the previous session, you really want to define what the pain point is and what the problem is you're trying to solve. And there are essentially two things that we're really trying to solve here. One is access. And the second is, it's very operationally burdensome to do an outcomes-based agreement. So the idea is that CMS will do it on behalf of the states. So we are currently in the process of working on that. I think that's one interesting potential model for some of these extraordinarily expensive therapies that are also life-altering with a very strong benefit.
Mark?
So I work primarily in automation in the back offices, but I'm a radiologist by training. And this first place where AI really impacted our field was in diagnostics and image interpretation. And so we've had about 8 years now of development in the payment structure and payment models for that world. And I think there has been a lot of development. So we've moved from traditional CPT codes were starting to evolve into NTAP payments, which are starting to create incentive programs that allow new people to start bringing new technologies in, Class 3 CPT codes that give these kinds of technologies an opportunity, even though a temporary one, to sort of demonstrate their value. And I think that has given manufacturers and startups like ours the confidence that we need to enter the space and speak to our investors with confidence as well that there is reimbursement that's coming behind the development of these technologies.
Ellen, do today's payment models work? And if so, why do they seem so opaque, so complex, almost by intent in some cases?
So I think in terms of thinking about, one of our key goals is around transparency. And I think I'll actually put a plug in for this so that you all know this. But essentially, we are actually putting our model data now out. So researchers used to be able to use the claims data, but they didn't know who was participating in our models. So now we're actually making all those data available as well as what we've collected from the model participants. And I think the idea there is that we're not the only people who can kind of mine what innovation, what actually happened, and where there were improvements. I think in terms of the Innovation Center, we are really focused on changing the incentives. So we have a lot of models, not as focused as CGT, but broader models, like accountable care organizations, where we essentially give the physicians maybe a primary care cap or a partial cap, or an example of an oncology care model, a care management fee on top of their regular Medicare payments. So it's really changing the way they think about the care. And the goal of that, in addition to really being able to transform their practices, is to simplify the payment. I think a lot of the practices, a lot of the ideas that are coming to the Innovation Center, almost all of them, are from the physician community, where we work with them to understand what is it that you think is currently not working, and what is the design of the model that may meet those needs.
Similar question to you, Mark, but let me twist it a little bit, turn it more toward what you do, and that is, how can artificial intelligence make the payment models more understandable, more efficient, so that more of the cutting-edge new drugs and therapeutics can get to the most people in an effective and affordable way?
Yeah, I was struck during Dr. Venter's talk about how we got very, very good at generating lots of data, not just genetic data, genomic data, but also healthcare data through the implementation of EHRs, through the ACA. And one of the missing components of that was how, we increased the scope of our data. Where was the systems that reduced the scope of it so we understand all this stuff? And that is what generative AI is particularly good at. It's particularly good at taking big scope data and reducing it in terms of scope so that you understand it. And I think that makes it more possible for you to determine where the actual levers of value are, so that you can start to create the appropriate incentive programs.
Ellen, value-based care models is a term of art that I'm not terribly familiar with, so maybe you can educate me a little bit there. But how do those models, or how can they be made to align with today's advancing therapeutics and medicines, so that the most people can get the most effective treatments at the most efficacious price?
So value-based care at its core is really thinking about paying for value, paying for quality, rather than just volume. So that's sort of what it is at its core. In terms of, though, directly to your question, we actually did a strategy refresh about 2 years ago. And one thing that we found is that in our model tests, we actually had an underrepresentation of low-income and Medicare providers. And so we had to regroup and think about, how do we include a broader set? Like, for example, we were excluding FQHCs because they're paid on a different payment system. We realized we can't do that if we want to have a broader cross-section of the Medicare population. But in terms of therapies, we do have waiver authority. So in the example of something like the cell and gene therapy access model, we can pay for more things. And in the example of that model, one thing that's really important is fertility preservation. And so since we have that waiver authority, for the states that do come into the arrangement that we are working on, this hasn't happened yet, but assuming it does move forward, they would then be eligible to cover fertility preservation.
Mark, how can or where can public and private partnerships play a role in creating payment structures that are effective, efficient, and enhance availability and affordability?
Well, I can speak to when we first started trying to figure out payment models for the application of CovNets for interpreting diagnostic imaging. That was a lot of conversations between GE, like the stakeholders within the medical imaging manufacturers. The professional societies were a big part of that. So the ACO, the College of Radiology, ACC, the College of Cardiology, and the FDA. And I think that conversation was really, really critical for the ultimate development of the policies that you now see with software as medical device. So I think those kinds of conversations really enabled the incentive programs that we now see today.
Ellen, I guess the sweet spot in all of this is creating payment structures and pricing that both incentivizes innovation on the one hand, but is also, and the rewards, as the previous guest said, for the people who come up with the best ideas. That's one of the great engines of progress, number one, and of the American experiment, seems to me. So how do you get to that sweet spot where, on the one hand, you have incentivized innovation, but on the other hand, maximized access at affordable prices? The two seem to be kind of at odds with one another. How do you thread the needle?
So in terms of how we think about it, we are trying to design models that improve care. So if you think about any of our models, there has to be a defined mechanism of change. And I think that that's really important, because otherwise it would be really hard to evaluate them unless we were really clear about the intervention and what we hope to achieve. In terms of thinking about that as a public-private partnership, almost everything we do is a public-private partnership, because especially, we're doing most of these models on a voluntary basis. So for example, in the CGT model, the manufacturers have to come in. I'll give another example, just because he mentioned Sherry Ling, who was instrumental in developing this model, but we are also just launched a dementia care model. And I know there's some folks in New York who are really helpful in that development, but essentially there we're providing a coordination fee to practices to manage dementia care and provide caregiver education as well as respite care. And so in the example there, we're really encouraging private payers, specifically Medicare Advantage, to adopt the same model. And that's to make sure that the physician practices participating will have enough beneficiaries that can be included to really change their practice.
Same question to you, Mark. How do you thread that needle or hit that sweet spot between pricing structures and payment structures that incentivize innovation and reward breakthroughs on the one hand, but also ensure access, affordability?
It's interesting. Back in 2016, we were talking a lot about when AI, in my field, when artificial intelligence was starting to hit diagnostics. There's a lot about how are we going to get CPT codes, how are we going to get the CAC to, how are we going to have those kinds of conversations. These days, I don't talk about that so much. It's actually. If you're automating the back offices, is that giving your nursing staff more bandwidth to actually address the needs of your patients? Are you using ambient scribes so that you can actually look at your patient in the eye? And so I think that's actually starting to address some of the core considerations that we really think about with VBC and other models. And so I think this may or may not directly answer the question, but I think what's happened over the last couple of years is we've moved from this is the way you traditionally pay. How do we pay for AI? This is the way that we traditionally pay for intervention. So how do we line that up? Now it's more well, this is just good business practice. This allows us to do our jobs more effectively with fewer people.
Ellen, you may have touched on this in one of your previous answers, but let me just rephrase the question and get you to take another whack. And that is, from where you sit, what are some of the coming innovative payment structures that can simplify the process, incentivize innovation, create affordability and access to drugs? What's in the pipeline that could help solve whatever problems there are in today's regime?
Yeah, so I think I talked a little bit about the cell and gene therapy access model. I'll tell you about another model. So a couple years ago, I think I alluded to the fact that we did a strategy refresh. And as part of that, we talked to a lot of folks like you, but also to a lot of beneficiaries and a lot of beneficiary groups. And one thing that was really clear was it wasn't only the cost, it was also the predictability. So the predictability at the pharmacy counter, how much am I going to owe for this prescription? And so one thing that we have just put out and announced that we're working on is called a Medicare $2 drug list. This is voluntary, but essentially Medicare Advantage plans and PDPs would come in and offer this. It would be for 150 drugs. And it would essentially mean for those 150 drugs at the pharmacy counter, you know they're only $2. And that's actually a request for information is out on that, so I'll put in a plug that if you want to provide comments, they're due December 9th. But I think, after talking with beneficiaries, we think that sort of intervention will be really helpful in terms of increasing that predictability.
Mark, let me pose the same question to you. Do you see something on the horizon that can make payment structures, payment regimes more rational, more effective, more efficient for more people?
Yeah, I think so. I mean, I'm going to speak again to sort of the RCM component of this, and then I'll tell you how it makes sense for the patient. But, every day, all day, there's a war happening between the payers and the providers. The payers are setting up roadblocks so that the providers can't get prior authorizations for the medications that their patients need. And this is day in, day out, 24/7, people are fighting. All right, so we're working with Northwell to build out solutions that enable providers to create really well documented, comprehensive prior authorizations for, say, transitions to care. And what's going to happen on the other side is that payers are going to create their own bots, and they're going to basically get better. And then the providers are going to get better, the payers are going to get better. Okay, so let's imagine a world that's not dystopian, where there's just an API where people talk rationally about why a patient should be getting the care that they should and compare it against well-documented professional society staples that dictate why people should get the care that they can. If you get that level of transparency, which you can with using these kinds of technologies, then it's not only transparent to the providers and the payers, but it's transparent to the patients. And so I think that's where we're hopefully going. Now, I'm an entrepreneur, so I'm an optimist, but maybe in a couple of years.
Ellen, Mark used the word fight, and I have to say that I'll bet you everybody in this room at one time or another has had to fight for some authorization for a medicine or for a medical procedure or for a therapy, physical therapy after a surgery or whatever. I certainly have. My wife is going through it right now on HRT therapies and getting that approved for her. Why is it such a fight? Why and why is it so non-transparent? With emphasis on the fight.
Yeah. No, definitely appreciate that. And we actually hear about that a lot from providers, really thinking about, to be transparent, most of our models are actually on the Medicare fee-for-service side, where we don't hear that, and I think it is pretty transparent. On the Medicare Advantage side, there's definitely been instances where we've heard about that, and I think you've seen our colleagues working.
Medicare just pays what they say they're going to pay to the
Right.
hospital provider.
Right.
And it's a set fee.
Yeah. I mean, I do think that, so putting that aside, sort of the prior auth, which colleagues of ours are definitely hearing a lot about and taking very seriously, I think that when we test these models, we don't want to create a disincentive to use a novel therapy. So I think that if you think about, something like the oncology care model where we pay like a lump sum, we essentially calculate what your expected payment would be over 6 months. And then in oncology, the therapies are coming out rapidly. And when the person from FDA was talking about the pipeline, we talk to them all the time because there are things constantly coming out. We actually do make an adjustment. So if you use a novel therapy, it sort of pops out of that system. And I think that's appropriate because we don't want these models to disincentivize. We want them to sort of be neutral related to that sort of change.
Go ahead.
Yeah, you said it. I mean, this is really fundamentally about alignment of incentives, right? So if you can forget about the technology, I love technology, but if you can't align incentives across the payers and providers, then you're basically taking technology, finding ways for you to fight each other more effectively. But if what you can do is use the technology to elevate, can generate a shared understanding, like this patient's situation is this. We're going to very quickly determine what the patient should get based on mutually accepted criteria. then there's less misalignment of incentives. There's a long way to go, but I think that's the promise of things like artificial intelligence, is to elevate, elucidate, make things transparent, and then ultimately make it more understandable.
Well, I want to thank you both for helping me achieve the one goal of my day every day, and that is to learn something new. You've done that, and now I have to go and read teleprompter. Thank you all very much. Have a great lunch, everybody, and a good rest of the day. Thank you.